The following podcast is part of a certified educational activity titled Making Precision Decisions for Patients with EGFR Mutated Non-Small Cell Lung Cancer. Success Strategies with Targeted Options, Potent Combinations, and Emerging Agents. Access the entire activity and complete the post-test at peerview.com/EVZ860. Downloadable slides and practice aids are also available.
Hi, my name is Pasi Yen from the Dana-Farber Cancer Institute in Boston, Massachusetts, and welcome to our program today, Making Precision Decisions for Patients with EGFR Mutated Non-Small Cell Lung Cancer. I am joined by my colleague and co-chair, Dr. Girard, who will introduce himself.
I'm Nicolas Girard. I'm the head of medical oncology at Institut Curie in Paris.
So our goals for today are to augment your knowledge of the latest evidence supporting the use of different EGFR-targeted therapies and combinations in EGFR-mutated non-small cell lung cancer, and also to equip you with the skills for selection and sequencing of established and emerging therapies and combinations in EGFR-mutated non-small cell lung cancer. First of all, we'll lay the foundation for precision medicine EGFR-mutated non-small cell lung cancer and discuss real-world barriers in testing and treatment. EGFR mutations are found commonly and come in various different subtypes. They are found across stages of non-small cell lung cancer, and the common ones include the exon 19 deletions and the L858R mutation. However, there are other categories, including the exon 20 insertions and the other ones, which include the G719X and L861Q mutations.
It's very important to have the results of the mutation profile and the biomarker before starting the treatment of patients with advanced non-small cell lung cancer, because it's a kind of different ways to envision the strategy. In patients with molecular alterations, we will go with targeted agents. In patients without such alterations, the treatment will be based on immune checkpoint inhibitors plus minus chemotherapy. And it's very then important to have the results of the biomarker testing results before starting first-line treatment. And we have seen over the past years an increase in the availability of molecular alteration results before starting first-line treatment. So very important to see that in more than half of the patients we have this information before starting. We need to increase that, obviously, because more and more alterations will lead to a first-line treatment with targeted therapies. We have seen that those gaps exist not only in metastatic non-small cell lung cancer, but also in early stage lung cancer patients. Again, we will discuss not only patients with advanced disease, but also patients with resectable or resected non-small cell lung cancer, for whom we also need to get this information regarding mutational testing, NGS results, as well as PD-L1 status. Very important and to get this information, to make the right choice, but also to keep in mind the fact that in patients with molecular alteration, especially EGFR mutation, when we start with standard of care treatment, especially immunotherapy, we do not get sufficient efficacy. Here are some of the data from the Pacific trial, so locally advanced non-small cell lung cancer, durvalumab as consolidation therapy after chemoradiotherapy, and in patients with EGFR mutated non-small cell lung cancer, there is no benefit with the addition of durvalumab versus placebo, highlighting the fact that those patients require targeted agents, not immune checkpoint inhibitors. So it's clearly two different groups of patients, those patients with molecular alterations, including EGFR mutations, and patients without such alterations.
We'll now move on to dissecting the evidence to inform personalized first-line therapy for advanced metastatic EGFR mutated non-small cell lung cancer. So these are the current guidelines for the treatment of advanced EGFR mutated non-small cell lung cancer. You can see the recommendations for the common EGFR mutations in the left. On the right-hand side for patients with the EGFR exon 20 insertions, and in the middle for patients with other EGFR mutations, including the S768I, L861Q, and the G719X. For the common EGFR mutations, osimertinib is a standard of care based on the FLORA trial, which compared osimertinib to either gefitinib or erlotinib, with an improvement both in median overall survival as well as overall survival being 38.6 months compared to 31.8 months for the comparator EGFR TKI. More recently, we have seen the FLORA-2 trial, which added chemotherapy to osimertinib, and that combination led to an improvement in progression-free survival from about 16.7 months for osimertinib alone to 25.5 months for the combination, and more recently also to an improvement in overall survival with osimertinib monotherapy being 37.6 months and the combination being 47.5 months. And so the median is about 4 years for the combination of osimertinib and chemotherapy. If we look at specific subsets of patients, including those with liver metastases, with bone metastases, osimertinib chemotherapy does patients do better. This is for progression-free survival in all cases with the combination compared to osimertinib monotherapy. This is most evident perhaps in patients with CNS metastases, where there's a almost doubling of the median PFS for patients treated with a combination compared to osimertinib. In patients without CNS metastases, there's still an improvement for the combination over single-agent osimertinib, but it is more dramatic in patients with CNS metastases. And if we actually look at responses in the CNS, we see that in patients treated with osimertinib and chemotherapy, there is a much higher overall response rate compared to osimertinib alone, including more patients who achieve complete responses with the combination. And in fact, the median duration of response had not been reached with the combination compared to 26 months with single-agent osimertinib. Now, we also know that there are some other molecular features which may lead to poor prognosis in advanced EGFR mutant lung cancer, and TP53 alterations, which happen in roughly half of the patients at the same time, are one of those alterations. And here is the comparison of osimertinib chemotherapy to osimertinib in patients whose baseline tumors do not or have alterations in TP53, and the combination leads to improvement compared to single-agent osimertinib in both cases. P53 mutations are a poor prognostic factor, and in both cases, if you, for example, look at the osimertinib curves alone, you can see that those with P53 alterations have a shorter PFS compared to those that do not. Another prognostic factor is the baseline detection of EGFR mutations in plasma circulating tumor DNA. And here too, the combination does patients do better compared to single-agent osimertinib In patients without detectable plasma ctDNA mutations, in fact, the PFS curves are much closer to each other, although there still is a modest benefit of osimertinib and chemotherapy. Here, too, you can see that baseline detection of ctDNA mutations is a poor prognostic factor in patients treated with osimertinib alone. In addition, those patients who have baseline detectable ctDNA, if they're reevaluated at week 3 or week 6, you can see that there is a high degree of clearance of ctDNA at week 3, a higher percentage with a combination compared to single agent osimertinib, and roughly similar percentages, 88 and 89%, not detected in patients at week 6 of treatment. So, and as mentioned, we know this is a poor prognostic sign, and lack of clearance of ctDNA is also a poor prognostic indicator.
At the last ESMO 2025 meeting, we have seen some updates regarding the FLAURA2 overall survival data, highlighting the fact that we have a benefit in favor of chemotherapy plus osimertinib versus osimertinib as a single agent, also in the patients with poor prognosis factors, and this includes not only the baseline CNS metastasis, but also patients with baseline liver mets, bone mets, patients with molecular features associated with poorer outcome, including the late 50LR mutation, TP53 co-mutation, and detection of plasma EGFR mutation in the ctDNA. So we see that we have a broad efficacy of the combination versus osimertinib, also highlighting the fact that there are no subgroups of patients where chemo plus osi is not worse. I strongly believe that the benefit with osi plus chemotherapy versus osimertinib is consistently observed regardless of these baseline prognostic factors.
In terms of safety on FLAURA2, the combination of chemotherapy added to osimertinib does add side effects, and you can see a summary of those. Now, most of those are side effects associated with chemotherapy, including nausea, diarrhea, anemia, fatigue, and there are no new side effects when chemotherapy is added with osimertinib to chemotherapy compared to osimertinib alone. The side effects tend to be the greatest during the first 4 cycles of treatment with chemotherapy, since that is the duration which combination chemotherapy is administered. And once you switch to the maintenance phase, they tend to lessen over time.
Another study that came out over the past years is the Mariposa phase 3 trial that assessed the combination of amivantamab, which is a bispecific EGFR MET antibody, plus lazertinib, a third-generation TKI. This combination was compared to osimertinib in the first-line setting for patients with common EGFR mutations. We have a benefit in terms of progression-free survival in favor of the combination of amivantamab plus lazertinib versus osimertinib, with a median PFS of 23.7 months versus 16.6 months with osimertinib. We also have a median overall survival benefit with this combination, with an estimated hazard ratio of 0.75. Osimertinib median overall survival was 36.7 months and not reached in the amivantamab plus lazertinib combination arm. So the estimation is that the benefit is higher than 12 months with the combination. Interesting to see that in Mariposa, we had data on intracranial PFS in those patients with baseline CNS disease. Very interesting to look at the long-term outcomes in those patients. And at 3 years, we had an intracranial PFS that was almost doubled with amivantamab plus lazertinib versus osimertinib. We also have some data with TP53 co-alterations. Again, we know that this is associated with poorer prognosis in those patients. Don't know whether it's a biomarker that can be used in the clinic to stratify patients with a higher risk of early disease progression. Like in FLORA2, we see that in MARIPOSA, the combination is associated with a benefit in those patients with TP53 co-mutations. We have seen also data based on detection of ctDNA at baseline in this MARIPOSA trial. We see that we have a benefit with the combination of amivantamab plus lazertinib versus osimertinib in those patients with detectable baseline ctDNA. We also see a benefit probably with a slightly lower magnitude in patients without detectable baseline ctDNA. Same thing as for FLORA2 with the study of the clearance of ctDNA at week 9, again, favoring the combination arm. Looking at patients with brain mets versus no brain mets, again, we see similar figures for median PFS with osimertinib as we saw in the FLORA2 study. And we have a benefit with the combination of amivantamab plus lazertinib, both in patients with and without brain metastasis, with similar hazard ratio in those two subsets of patients. In MARIPOSA, the safety profile is mostly related to cutaneous and dermatologic adverse events. We also have frequent infusion-related reactions with the first infusions of amivantamab. We see that, like in FLORA2, most of those side effects occur within the first months of treatment. That those cutaneous side effects are more frequent at the initiation of the treatment. Other side effects include adverse events related to the MET inhibition, especially with peripheral edema and hypoalbuminemia. Another point with this safety profile for MARIPOSA is that we do not have chemotherapy-related adverse events. One way to prevent the side effects associated with amivantamab plus lazertinib combination is to implement prophylactic approaches, and this includes the Cocoon dermatologic regimen, which is a prevention that includes topical creams, antibiotics, and clindamycin lotion to prevent the dermatologic side effects. And in the Cocoon randomized study, we saw almost a twofold reduction in those side effects when implementing this prophylactic regimen. SKIPPER was a study that looked at the infusion-related reactions to amivantamab, implementing dexamethasone in the 3 days before initiating amivantamab, leading to a reduction by threefold in the risk of infusion-related reaction and also reducing the severity of those reactions. And finally, we have an increased risk of venous thromboembolism associated with this combination of amivantamab plus lazertinib, and prophylactic anticoagulation is recommended for the first 4 months of treatment, again leading to a reduction in the risk of venous thromboembolism. In Cocoon, with this dermatologic management and prophylaxis, we have a reduction in all the cutaneous side effects, including skin reactions, pachonychia, adverse events involving the scalp, the face, and the body. It's quite easy to implement because oral doxycycline, clindamycin, and ceramide-based moisturizers are widely available. It requires education of the patients regarding this prophylactic regimen, and obviously it requires a good equipoise between the patient and the medical team. Those modifications are possible with the combination of amivantamab plus lazertinib, and with the implementation of the dermatologic prophylaxis, there is a reduction in the need for dose reduction, and we also see a reduction in the risk of discontinuation of any of those drugs. Finally, subcutaneous amivantamab has also been made available, and we have this PALOMA-3 study that compared amivantamab subQ versus intravenous plus lazertinib, and we have in the late line setting data showing the non-inferiority of the subQ regimen versus the intravenous regimen. We also see that with the subQ administration of amivantamab, there is a significant reduction in the risk of infusion-related reaction from 66% of the patients to 13% of the patients. And with the implementation of prophylactic anticoagulation, also the reduction in the risk of venous thromboembolism. PALOMA-2 was conducted in the first-line setting, so similar settings than the landmark Mariposa study, with the subcutaneous amivantamab every 4 weeks, plus lazertinib, and showing similar response rate as in Mariposa, as response was observed in 82% of the patients.
There are other emerging frontline combinations being studied, and these are summarized in this slide. Some of these utilize compounds targeting emerging resistance mechanisms, such as MET amplification with savolitinib. There is another third-generation EGFR inhibitor called almonertinib, which is being also combined with chemotherapy, kind of like the FLAURA2 trial. And there are trials combining osimertinib with the anti-TROP antibody drug conjugate Dato-DXd compared to either osimertinib or platinum doublet chemotherapy in the TROPION-Lung 14 and 15 trials, respectively. Now let's discuss a case. So this is a 60-year-old woman with no history of smoking, presents with cough, dyspnea, generalized fatigue for 3 months. PET-CT reveals 3-centimeter left lower lobe lung nodule and large mediastinal nodes and multiple FDG-avid hepatic hypodensities and extensive bone marrow involvement consistent with skeletal metastases. MRI of the brain reveals a 4 sub-centimeter parenchymal lesions consistent with metastases, however, without any perilesional edema. FNA of the lung reveals a TTF-positive lung adenocarcinoma, and biomarker testing reveals an EGFR exon L858R mutation and a PDL1 TPS of less than 1%. So I think we should first discuss, and I'll ask my co-chair, Dr. Girard, what first-line treatment would you recommend for this patient and why? And maybe discuss, would you think about a combination or single-agent therapy?
I think we have shown that combination is doing better than osimertinib alone. So in these patients without comorbidities, quite young patient, we have an aggressive disease, we probably would go for a combination. Then chemo plus OSI or AMI plus laser, that's the key question. Right now, I do not see any data supporting one or another of those two combinations for these patients. We have seen the CNS data that you discussed based on the FLORA2 trial with this high rate of complete response. This may probably lead to discuss FLORA2 for these patients. AMI plus laser is another option with the advantage of being chemo-free. We have also seen the intracranial PFS data from Mariposa. So I think that both of these options may be discussed for this patient.
Yes, I would agree. I think this is somebody, given the extensive nature of the disease, as well as symptoms, that a combination approach here makes sense over single agent osimertinib. And I agree there is no clear factor that would necessarily totally sway me in one direction or one combination over the other, but I do think the nature of what we're seeing here clinically does suggest that this may be somebody who perhaps wouldn't do as well with just single agent osimertinib. Now, how would you, in terms of AE prophylaxis and management, how do you coordinate this at your center? Do you involve dermatologists or other treatment or team members to help with that?
Well, it's very important, especially for the Mariposa regimen, to have the dermatologist and nurses, coordinating nurses on board, to make sure that we detect the side effects when they occur with grade 1, to avoid these moving to grade 2 or grade 3. Very important to have an accurate education of the patients regarding those dermatologic adverse events, have a close clinical monitoring, so it may be through telesurveillance apps or just with a call to the patients. Usually I see my patients after 2 weeks of those treatments if I implement AMI plus laser, just to make sure that we do not have severe adverse events.
Yes, we do something analogous to what you mentioned, and also obviously a prophylaxis, especially for the AMI laser with the skipper regimen and dermatologic prophylaxis. Now, the sub-Q formulation is the data is very interesting. We unfortunately don't have it available in the U.S. at the moment, and you do in Europe. Have you switched over completely to that, or are there still, or how do you decide on that?
Well, not available yet in France, but I feel that given the lower risk of infusion-related reactions and also maybe the better safety profile overall with the sub-Q formulation, it would be the way I would initiate the patients for the Mariposa regimen.
Yes, I would agree, and I think it'll shorten the time the patient has to also be in the clinic from just a few minutes to much longer for the intravenous formulation. So I think we're both looking forward to that being more widely available at our respective places. Now let's look at some of the other considerations for this patient. Would presence of liver metastases make a difference?
I don't think so. I think we have an efficacy superiority of the combinations, whatever are the prognostic factors that we have in those patients, including liver mets, including TP53, as we discussed, including detectable ctDNA. This is not something that we look at in our patients yet, but yeah, I feel that if we decide to go for a combination, we will have superiority versus OSI mono, whatever are those high risk or poor prognosis factors. Now, the question is probably about the age of the patients, because in elderly patients with EGFR mutated non-small cell lung cancer, we may be reluctant to treat with a combination. We know that chemotherapy with pemetrexed may be associated with a higher risk of side effects. So, yeah, in elderly patients, probably it's important to have an assessment with a geriatrist and so on to see whether the patient is a candidate for a combination versus osimertinib monotherapy.
Yes, I agree. Obviously, you have to be a chemotherapy candidate to receive the FLAURA2 regimen. And similarly, I think the patient has to be able to tolerate the Mariposa regimen, and that may be harder in older patients than younger patients. What about someone living far away? Would that be somebody you would perhaps think about single agent osimertinib because he or she can't come to the clinic that often?
Well, I'm not sure of that. I believe that obviously traveling and so on is something that is important to consider. But at some point, when we see the magnitude of benefit with the combination, I feel I should try to convince the patient to come to receive chemotherapy or amivantamab, depending on the combination I choose, or to find a center closer to the patient home.
We both agree that we want to offer our patients the best treatment possible. And finally, if this patient hadn't had multiple brain metastases but had a solitary brain metastasis, how would you approach that? Still with systemic therapy, or would you use local therapies for that?
Systemic therapy for sure, and probably a combination, because the superiority of the combination is not only related to a better efficacy in patients with CNS disease, but in those patients with oligometastatic disease, we tend to also have a local treatment of the oligometastatic disease. So I would go for surgery or radiotherapy.
Yes, I think similar for us. Solitary brain metastasis, I would certainly consult with my radiation oncology or neurosurgical colleagues. Also, depending on whether there's edema with the solitary brain metastases, symptoms, etc., local therapy becomes more and more important, even in the presence of other metastatic disease, for sure. All right, let's change gears a little bit and talk about the changing arsenal of therapies for pre-treated EGFR mutated advanced metastatic non-small cell lung cancer. Now, resistance, when it happens to osimertinib, can be quite heterogeneous, and you can have multiple different types of resistance mechanisms occurring simultaneously. So you can have secondary EGFR mutations like the C797S mutation. You can have other amplifications of other oncogenes like KRAS, MET, HER2. You can have acquired rearrangements like BRAF or ALK or RET rearrangements, or transformation into small cell lung cancer. So resistance is very heterogeneous to frontline EGFR therapies. And if we look at resistance, for example, this is all done from ctDNA from the FLAURA2 regimen. You see resistance mechanisms to both the combination with chemotherapy and OSI monotherapy, but the spectrum remains generally similar between the two, meaning that you don't see any unique resistance mechanisms as a result of chemotherapy that you didn't see with osimertinib monotherapy. Now, they're fortunately delayed because of the improvement in PFS and OS, but the types of resistance are fairly similar. And similarly with amivantamab and lazertinib compared to osimertinib, you do see resistance mechanisms that are not that dissimilar, except acquired MET amplification and acquired EGFR resistance mutations were less frequent in the patients that received the combination compared to osimertinib. And we know from previous studies that amivantamab and lazertinib that combination does have efficacy against osimertinib resistance mutations, as well as cancers that develop MET amplification. So it's nice to see that there's less of those emerging if you start patients on the amivantamab lazertinib combination.
In MARIPOSA-2, this is a randomized trial that compared amivantamab plus chemotherapy versus chemotherapy alone in patients presenting with acquired resistance to osimertinib, so second-line trial, standard of care platinum-based chemotherapy alone, and here we assess the combination of amivantamab plus chemotherapy. We see a PFS benefit with the combination, the addition of amivantamab to chemotherapy with a hazard ratio of 0.48, moving from 4.2 months with chemotherapy to 6.3 months with the combination of amivantamab plus chemotherapy. So amivantamab plus chemo is one of the standard of care in the post-osimertinib setting. Also, very interesting to see that with this combination, we have an improvement, a trend in the improvement for overall survival. Still not yet significant, but you can see that the curve separate quite well in this study. Subcutaneous amivantamab may also be used in combination with chemotherapy in a regimen that is quite similar to that of the MARIPOSA-2 regimen with IV amivantamab. Cohort 3B from the PALOMA-2 study was presented at the ESMO 2025 meeting and reporting on consistent response rate and PFS as in the landmark MARIPOSA-2 trial. We can see a median PFS of 7.9 months, so clearly highlighting the value of this regimen for the patients presenting with acquired resistance to osimertinib. The COMPEL trial is a study that just compared the continuation or the discontinuation of osimertinib at the time of disease progression while under osimertinib. So osi plus chemo versus chemotherapy, randomized study, placebo-controlled. And looking at the primary analysis, we see a benefit in terms of PFS with a continuation of osimertinib when initiating second-line chemotherapy in those patients from 4.4 months with chemo, so quite similar than what we saw in MARIPOSA, in the MARIPOSA-2 in the control arm, to 8.4 months with the continuation of osimertinib. And this was related in patients not only to CNS PFS, but also an improvement in non-CNS PFS. So probably another strategy to treat those patients with acquired resistance to osimertinib. A third strategy for these patients with acquired resistance to first-line osimertinib is to switch to an antibody-drug conjugate targeting TROP2, so datopotamab deruxtecan. We have some data in the second-line setting from the TROPION-Lung 1 trial, so patients with or without genomic alterations, showing a benefit in non-squamous non-small cell lung carcinomas, and in the landmark TROPION-Lung 1 trial versus docetaxel, showing this trend towards an OS benefit. Focusing on the patients with EGFR mutated non-small cell lung cancer, we have the data from the TROPION-Lung 05 trial, which was a phase 2 conducted in those patients with EGFR mutated non-small cell lung cancer or other genomic alteration. Again, showing a median PFS of almost 6 months, so suggesting that datopotamab deruxtecan is an effective option in those patients after the failure of chemo and osimertinib. Maybe a biomarker for datopotamab deruxtecan is the TROP2 expression by immunohistochemistry, probably using more complex assessments than just the eye of the pathologist, using computational pathology approach, what so-called quantitative continuous scoring, so QCS, which is assessing the expression of TROP2 normalized at the membrane versus the cytoplasm. And overall, in patients with lung cancer from the TROPION-Lung 01 trial, those patients with TROP2 expression by the QCS NMR technique had a higher benefit versus docetaxel than the patients without such expression. Looking at those data with datopotamab deruxtecan, we saw this combined pooled data from the TROPION-Lung 05 and TROPION-Lung 01 trials, again showing a trend towards a benefit with datopotamab deruxtecan versus docetaxel for those patients with EGFR mutated non-small cell lung cancer. PFS 5.8 months and a median OS of 15.6 months. So it is obviously non-comparative data, but figures for PFS and OS that are probably better than that of platinum-based chemotherapy. And moving from the third line to the second line, we have some data from the OptiTROP-Lung 04 trial with sac-TMT in the second line setting that was compared versus chemotherapy, platinum-based chemotherapy, post first line osimertinib. In this study conducted in China, we see a benefit in favor of sac-TMT versus platinum-based chemotherapy, not only in terms of PFS, moving from 4.5 months to 8.3 months, and in terms of overall survival, not reached median, not reached with sac-TMT, and 17 months with chemotherapy. So again, highlighting the high efficacy of TROP2 ADCs, especially sac-TMT, for these patients with EGFR mutated non-small cell lung cancer, not only in the late line setting, but also in the earlier lines. And there are some trials ongoing in the first line setting with those agents.
Another exciting development in the treatment of patients who have progressed on EGFR inhibitor therapy is based on the HARMONY study using ivonescimab, an anti-PD-1 VEGF bispecific antibody with chemotherapy. And in this trial, showing a significant improvement in progression-free survival with the combination 6.4 versus 4.4 months, and a trend towards overall survival improvement as well, with some separation of the curves, 16.8 months for the combo and 14.0 months for the chemotherapy alone. There's a lot of activity in this space. There's an exciting new therapeutic modality for patients with EGFR mutant lung cancer. Finally, looking at combinations of MET inhibitors with EGFR inhibitors with the savolitinib versus and osimertinib versus savolitinib and placebo. You can see in this Savannah trial a much higher combination rate of response with the combination, 58 versus 16%, really making the case that you need the combination. You can't just switch to a MET TKI. You actually need to add it to an osimertinib to see this activity. And there is a phase 3 trial called Saffron currently ongoing. We also recently saw data at ASCO from this Sachi trial, which used the same combination, osimertinib and savolitinib, in patients who had MET amplification after development of resistance to first-line EGFR TKIs, but compared in this randomized trial to chemotherapy, leading to a significant improvement in progression-free survival, 5.4 months with chemotherapy, 9.8 months with the combination of savolitinib and osimertinib. So depending on the specific resistance mechanism, in this case MET amplification, there may be a remarkable benefit for adding a MET inhibitor to osimertinib, and that seems to be better than switching to chemotherapy. Other ongoing trials, I mentioned the Saffron trial, which looks at EGFR mutant patients with MET overexpression and or amplification after osimertinib treatment. Patients are randomized to that combination or chemotherapy. There's also the Orchard trial, which is a platform study of patients who have progressed on osimertinib, where they are randomized to different combinations based on the specific osimertinib resistance mechanism. Primary endpoint here is response rate, as well as bispecific antibodies, including the BLB01D1 and EGFR HER3 bispecific antibody that's being evaluated in this situation where the primary endpoint is safety and a recommended phase 2 dose. This is still in phase 1 evaluation.
So let's discuss a case now. I have 65-year-old patients, locally advanced and resectable EGFR mutated non-small cell lung cancer. This is exon 19 deletion, PD-L1 negative, who started first-line osimertinib. After 14 months, imaging tests showed pulmonary, liver, and bone metastasis. The patient remains asymptomatic, PS1. Repeated biomarker testing was conducted and shows no new targetable alteration. So, Pasi, what are the test assessments that you need before making your treatment decision, and what treatment would you recommend for this patient?
So here, I think that it's important to recognize that tissue-based testing at the time of resistance is important, which hopefully was done in this situation, as the person has pulmonary and liver metastases, which should be accessible to biopsy. Tissue-based testing, because you want to look at the histology, make sure there was no transformation to small cell or squamous cell. You can do NGS. You can do IHC-based studies for other potential treatment options. So IHC for HER2, for MET, which can help direct treatments. Now, assuming you do all those and the person does not have a new targetable alteration, I think your options here are the COMPEL regimen, which is to add chemotherapy to osimertinib, or switch to the Mariposa 2 regimen, chemotherapy and amivantamab. I think those are the main options. And although you mentioned about the QCS biomarker, it is not yet something that's widely available, which may help one choose may one think about TROP2 targeted therapy down the line, but we don't have a good biomarker at the present for the Mariposa 2 regimen. So I think it's one of those two regimens. I think it's meaning COMPEL or Mariposa 2, and I think it's a discussion with the patient.
Interesting. Yeah, it's very interesting to see that the COMPEL trial is actually something that seems to be simple and widely accessible, actually. Mariposa 2 is obviously associated with higher risk of dermatologic adverse events, and so this has probably to be discuss with the patients. And then I agree with you regarding datopotamab deruxtecan and other TROP2 ADCs that probably need more data in those patients. And we have some ongoing trials such as the TROPION-Lung 15 in this situation. But what if the patients previously received chemotherapy? So the FLAURA2, how does it change the way you decide for second-line treatment?
I think in that situation, if the patient received both chemotherapy and osimertinib already, I think there I would think more prominently about datopotamab deruxtecan, since it's that is the approved indication for patients who have received prior osimertinib and chemotherapy. So I would think about that for that specific individual.
No, I agree with you that it's unclear right now whether we can re-challenge platinum-based chemotherapy in those patients who previously received the FLAURA2 regimen. What is the time interval, the chemotherapy-free interval that we should consider if we want to re-challenge chemotherapy, and whether the efficacy is actually similar as what we discussed after OSI mono. In patients who previously received the Mariposa regimen, well, I do not expect Mariposa 2 to be effective because MET driven resistance is probably covered by the Mariposa regimen. So probably moving to chemotherapy. Whether we should continue the TKI is unclear right now. And again, the ADCs may represent an opportunity for those patients. I feel that if we have a MET amplification, well, based on the SACHI data, the Savannah data, it's probably very interesting to look at MET inhibitors in those patients.
No, absolutely. I would agree with that. That would be our standard approach as well.
I think that those patients, we need obviously to think about the treatment sequence, but still keep in mind that, well, the PFS figures for second line, third line remains far more limited than what we have in the first line setting. So the first line treatment choice actually drives the treatment sequence. And it's also maybe important to keep in mind that most of the lifespan of those patients will be spent on the first line treatment. We know that also many patients are not receiving second line or third line therapy. So very important to me to make the right choice in the first line setting.
Yeah, no, I would agree with that as well, and that your best opportunity for treatment is likely in the first line setting, and so I think that is an important consideration.
Moving to from the common EGFR mutation to EGFR exon 20 insertion mutations, we have seen more recently some data that show how we can extend the benefits of EGFR targeted therapies in this subset of patients. This is the Papillon trial conducted in the first line setting for patients with metastatic EGFR exon 20 insertion mutated non-small cell lung cancer. This is chemotherapy plus amivantamab versus chemotherapy alone. And in the Papillon trial, we have a significant benefit in terms of PFS, almost a doubling of the median PFS from 6.7 months to 11.4 months with a combination of amivantamab plus chemotherapy. Also a higher response rate, more rapid responses. So for those patients with EGFR exon 20 insertion mutated non-small cell lung cancer, chemotherapy plus amivantamab is the current standard of care in the first line setting. We know that amivantamab is also effective in the post-platinum setting for patients who would not have received the Papillon regimen in the first-line treatment. Based on the Chrysalis phase 1 data, we see the efficacy of amivantamab in those patients previously received chemotherapy. The efficacy of amivantamab is based on response rates, 40% of the patients, and a median PFS of 8.3 months. I previously discussed the safety profile of amivantamab, and actually very also interesting to see that the efficacy of amivantamab for EGFR exon 20 insertion is observed whatever is the type of insertion, because it's a very heterogeneous group of patients from a molecular standpoint. Again, sub-Q amivantamab plus chemotherapy may represent an opportunity versus amivantamab intravenous administration plus chemotherapy. We have this cohort from the Paloma 2 trial showing similar outcomes than that reported in the Papillon study.
There are also EGFR tyrosine kinase inhibitors that are specifically developed for EGFR exon 20. One of these is sunvozertinib, which was in fact recently approved in the U.S. And in patients with previously treated EGFR exon 20 mutated non-small cell lung cancer, you can see a response rate of about 45% for sunvozertinib, most of them being partial responses. And there are other trials ongoing, including randomized trials where sunvozertinib is compared to chemotherapy. Another exon 20 inhibitor called zipalertinib, which has also a fair degree of activity as a single agent, and a phase 3 trial is being done with zipalertinib added to chemotherapy compared to chemotherapy. There's also furmonertinib, which is another EGFR inhibitor with activity in exon 20 compared to chemotherapy. And finally, the BECOME study of becotarag with osimertinib is a phase 2 in patients with pre-treated EGFR exon 20 insertion. So a lot of activity in this space. We expect and hope for many new approvals in this space. And it's nice to have the ability to use tyrosine kinase inhibitors after amivantamab or amivantamab chemotherapy to give patients more options for treatment. All right, we'll move on to our next case. 55-year-old man presents with dyspnea. Workup reveals pleural effusion, pleurocytology, positive for adenocarcinoma, and a PET scan shows multiple bilateral pulmonary nodules, ECOG PS of 1. Liquid biopsy reveals an EGFR exon 20 insertion, and a tissue NGS reveals the same mutation. And the question is, what should be the first-line therapy and why?
Well, I think that this patient is a candidate for the Papillon regimen, so platinum-based chemotherapy plus amivantamab, standard of care in the first-line setting. We do not have that much data after the failure of Papillon. We know that some of the TKI for patients who had a progression while under amivantamab showed some efficacy, but this is limited subset of patients. So the treatment sequencing actually in those patients is still an area of investigation.
Yes, I would agree with everything you said, and also that the standard of care would be the Papillon regimen here with amivantamab and chemotherapy. Yes, there's some data on both sunvozertinib and zipalertinib having activity in patients previously treated with amivantamab, but we need to gather more information as those agents become more widely available to see what is the real activity there, and does it change with any of the other treatments. Also, the one other point to mention here is in the second line setting, there is not as much data on using datopotamab deruxtecan in patients with EGFR exon 20 mutant non-small cell lung cancer, although there's no reason to believe that there are such different cancers that you couldn't use datopotamab deruxtecan in the second line setting. So if you started someone on the Papillon regimen, that could be a consideration in the second line setting for those patients as well.
Moving finally from the metastatic patients to patients with non-metastatic EGFR mutated non-small cell lung cancer, we have seen recently data in patients with locally advanced or early stage non-small cell lung cancer. LAURA is a trial that was conducted in patients with unresectable locally advanced EGFR mutated non-small cell lung cancer after chemoradiotherapy. So in patients without disease progression after chemoradiotherapy, randomization was conducted to compare osimertinib until for a duration that was prolonged until disease progression in this experimental arm versus placebo. And the LAURA trial showed the benefit of consolidation of the osimertinib in those patients. With placebo, median PFS was 5.6 months, moving to 39.1 months with osimertinib. So we clearly see here that also for those patients with locally advanced non-metastatic EGFR mutated non-small cell lung cancer, we have a strong benefit with osimertinib. And we have an improved trend towards OS benefit with osimertinib in this study, as you can see with this separation of the curves, still an ongoing follow-up of the patients enrolled in this study.
Also, in the surgically resected patients, the ADAURA trial helped establish osimertinib as the standard of care adjuvant therapy in patients who have undergone surgery for early stage lung cancer that has an EGFR mutation, showing a significant improvement in disease-free survival in patients who receive osimertinib for 3 years after surgery, with or without adjuvant chemotherapy, which was mostly administered in that trial to patients who had lymph node positive disease at the time of surgery. This also led to an improvement in overall survival when patients received osimertinib in the adjuvant setting. If you look at on the left, patients with stage 1 to 3A disease, the median overall survival was 61.1 months, which was significantly better than with placebo. And a question arises, which we don't quite know yet, is does the improvement in overall survival mean an improvement in cure of the patients? And I think we need to see and follow patients after they stop osimertinib to see what happens to them, and do any of them develop or what fraction of them develop recurrence in the future. But this is certainly an exciting development to see our effective systemic targeted therapies to moving into the earlier lines of settings in the adjuvant or setting, or following local advanced therapy. And this is also happening in many of the other oncogenic subsets of lung cancer, but certainly with EGFR patients, this is led the way so far. Now, what about giving these agents prior to surgery? We've seen a lot of excitement about giving chemotherapy and immunotherapy in the neoadjuvant setting prior to definitive surgery in patients whose cancers do not harbor an oncogenic alteration. And we're now starting to get data on patients who have EGFR mutant lung cancer where they've been treated with either chemotherapy or osimertinib or osi chemotherapy prior to surgery. And certainly either with osi monotherapy or osi chemotherapy, the major pathologic response rate was much higher than with chemotherapy alone. There's an interim event-free survival analysis that favored patients who had received osimertinib alone or with chemotherapy. However, it's still immature. And over 50% of patients who had baseline N2 disease were downstaged at surgery with osimertinib-containing arms versus only 21% with chemotherapy. So I think it's an exciting development here too, and we'll need more follow-up from this and other ongoing trials that are evaluating similar approaches in patients with oncogene-addicted non-small cell small cell lung cancer.
Let's discuss a case. So, 65-year-old woman, never smoker, cough. She had a CT scan showing left upper lobe mass, hypermetabolic at the PET CT with one hilar lymph node, no distant disease, brain MRI negative. The diagnosis was made with transbronchial biopsy. This is adenocarcinoma, EGFR exon 19 deletion, PD-L1 high, so CT3N0 disease. The patient receives neoadjuvant cisplatin and pemetrexed and undergoes robotic lobectomy. And she comes to you to discuss the adjuvant treatment.
So here, I think with an EGFR mutant lung cancer that's been surgically resected, having received neoadjuvant chemotherapy alone, the standard of care would be adjuvant osimertinib. Patient has stage 2B disease, so that is someone who would have been enrolled in or would have been eligible for the ADAURA trial. So I do think that's reasonable. I think it's important to get those biomarker testings done from the transbronchial biopsy, as in this case was an EGFR exon 19 deletion. Had the NeoADAURA or other trials been ongoing, the patient could have been eligible for that trial. But I think in the absence of that approach, having patient receiving chemotherapy with an EGFR mutant surgically resected lung cancer, the standard of care here would be adjuvant osimertinib.
And very important to also have the results of the molecular testing before starting neoadjuvant treatment, because in this patient, we should not give chemotherapy plus immunotherapy as neoadjuvant treatment. Those patients, the EGFR mutated patients, were excluded from those neoadjuvant or perioperative trials.
Yeah, and the question that sometimes comes up clinically is, what happens at the end of 3 years of osimertinib treatment? And we're now, I'm sure you are as well, starting to see many patients who are reaching their 3-year mark and they're doing well. They don't have recurrence. And this is an area that is unknown about the optimal duration of osimertinib treatment. There is another trial ongoing that evaluates, as a single-arm trial, evaluates a longer duration of osimertinib treatment. But we are still also learning about what happens if patients do progress on adjuvant osimertinib. What fraction of it is it? What fraction of that happens once they stop the treatment versus what fraction happens during treatment? And I think trying to understand that will hopefully help also guide the duration of treatment, as well as the data from the ongoing clinical trial.
Well, I think that we have explored many phases of EGFR mutated non-small cell lung cancer. probably there is more complexity than before in terms of available options, stratification of patients. Probably we need to have some more biomarkers to decide for the treatment of patients, not only at the baseline, but also at the time of acquired resistance to each line of treatment. So probably back to biology, very important to do rebiopsies for those patients. We showed how the disease may change over time and after the exposure to one or another treatment.
Yeah, it's exciting to see combination therapies for patients with metastatic EGFR mutant lung cancer improve survival. It's exciting that we have new exon 20 inhibitor therapies coming out and new approaches in general for treatment of patients. And I agree with Dr. Girard that biomarker-guided therapies tend to be the most effective, and we should make sure that we find and evaluate the appropriate biomarkers at diagnosis, at progression, following surgery, et cetera, to be able to deliver optimal therapies for our patients. Thank you for all of you who viewed this program today. I hope it was of educational value and you learned something that will be helpful the next time you see a patient with EGFR mutant lung cancer in the clinic. And I'd like to also thank my co-chair, Dr. Girard, for his insightful comments and discussion.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by independent educational grants from AstraZeneca, Daiichi Sankyo Incorporated, and Johnson & Johnson. To access all materials for this activity, visit peerview.com/EVZ860.